Good afternoon, everybody. Hopefully everybody can hear me. My name's Chris Hendriksz, if we've not met before, and it's my great pleasure this afternoon to start this series of webinars, which is a joint project between the IGA, the International Gaucher Alliance, the International Working Group for Gaucher Disease, and a rare cause, and it's all coming together to just focus on patients with what we traditionally called Gaucher disease type 3 or Gaucher disease with neurological phenotype, for whichever terminology people are using. And we are really privileged today that we've got some world-renowned speakers for you. Yeah, I've got Derralynn Hughes, who's going to be talking about, and she brings an adult perspective into this. And then Aimee Donald, who is more on the pediatric side, but both of them world experts in this field, and be really delighted to hear their takes. But I do want to tell you now, remember, it's a series of 4 in total. So this is only the first one. The next one is in October. And then in 2026, we are going to move on to another 2. So if I get the next slide, I'll just give you some other information. So just to let you know that this webinar will be recorded and shared afterwards. We know not everybody will be able to do it. We will be running a poll towards the end of the session. We really want to know what is perceived and how do we shape the next 3 webinars and keep things going forward. Please put your questions in the chat and we'll try and get through all of them. And then useful materials will be shared afterwards. And again, for those, just to know that the South African Medical Association has agreed for 1 CPD points for those which are collecting them. So I think that is all of the practical arrangements, but please keep engaged. And we're really looking forward to all of this. And I'm going to hand over firstly to our speakers. And from what I can remember now, you're going to kick us off, Derralynn, and then we're going to move between you two. So over to you, Derralynn.
Thank you very much. So I'm Derralynn Hughes. I'm the chair of the International Working Group on Gaucher disease and a physician working in the UK. So I'm here today with Aimee Donald, who's led a lot of research in the UK on neuronopathic Gaucher disease. So we're going to do a little joint act with you talking about neuronopathic Gaucher's diagnosis and clinical features. So Aimee's going to go through the clinical features, and then I'm going to talk a little bit about the diagnosis. There we go. Over to you.
Perfect. Fabulous. So lovely to be here and to be talking about our favourite topic of neuronopathic Gaucher disease. And really, we're going to start with the feature or the clinical feature, which is sort of been used as the defining feature of neuronopathic disease, which is this oculomotor abnormality, so an eye movement abnormality. And this is something that you kind of have to see to be able to get your head around what we're talking about. But we're talking about a difficulty in jumping the eyes between 2 positions. So it's about keeping the head still and moving the eyes from one point to another. And there's a difficulty in initiating that movement, and then there can be a slowing and a kind of smoothness to that movement. And over time, there can be loss of that ability to move. And so naturally, our brains and our eyes, they compensate for this difficulty in initiating eye movements. And so particularly something we see in children is that they'll flick their head. And so they do this compensatory head thrusting movement. And so while you may find it difficult to identify the eye movement abnormality, the feature that you may see is just these jerky little head movements, and I always talk about some of my pediatric patients looking like little birds. The way they look around is this very jerky movement to their head, and sometimes it can be very subtle, sometimes it's something that evolves over time, but it is the key clinical feature which distinguishes a patient with Gaucher disease from having non-neuronopathic disease or type 1 Gaucher disease to being neuronopathic or type 3. And we do think that over time this can evolve into a vertical saccade difficulty, and we certainly see that in some of our older patients, but really we're looking at the horizontal. Now, there is a very small group of patients, particularly with a kind of an attenuated form of neuronopathic disease, who may present with a vertical impairment. But I think if you saw a primary vertical impairment in a child who you thought had Gaucher disease, maybe hadn't fully formed that diagnosis, the alternative diagnosis you need to think about there is Niemann-Pick type C. So we think of Niemann-Pick type C as a challenge in vertical, and in Gaucher in the horizontal plane. So those are the key features. If we have time or people are interested, it would be useful. I can show you some videos of those eye movements at the end of the session. So when we think about neuronopathic Gaucher disease overall, we're thinking about a patient who has a diagnosis of Gaucher disease and they have this addition of neurological involvement. And it's a really, it is a wide spectrum of how this affects patients. It can be incredibly severe with progression and neurodegeneration during childhood, or it can be very slow and progressive throughout life. And the time at which those features occur vary between patients quite significantly. Seizures can be a problem in the most severe forms of disease, and we typically talk about a progressive myoclonic epilepsy. So that would be in keeping with other inherited metabolic disorders where we see a high burden of difficult to treat myoclonic seizures. Some patients will have generalized tonic-clonic seizures, and some will have focal seizures. So there's a whole range of different seizure types or semiologies that we'll see. And in most patients with confirmed neuronopathic disease, particularly where it's established in childhood, you'll see background slowing on the EEG. But the EEG tends not to be particularly helpful necessarily in terms of management. We do see movement disorders in some of our patients. Now, these are primarily sort of increased tone, increased reflexes, and they can be subtle and not give children or adults any problems. But over time, that tone can become more problematic, and you may see patients with dystonia. As patients get a little bit older, they start to have more cerebellar signs. And so clinically, that might manifest as tremors or ataxias. But we have to remember the role and the connection of the cerebellum in our intellectual and social communication. And so I think sometimes some of the cerebellar symptoms actually manifest as sort of autism or these kind of social communication challenges. We talk about neuronopathic Gaucher disease and the kind of progressive nature of neuronopathic Gaucher disease, but cognition is often preserved in our patients. Or what you may find is that there's developmental gains, but rather than there being cognitive loss, you may just see a plateau. There is a group of patients with severe forms of disease who maybe seem to do not too badly through childhood and early adolescence. And then in that kind of early adulthood period, I think the kind of intellectual burden of life, the way your responsibilities change, you kind of get this sort of almost delayed adolescence, and the impact of living with disease for such a long time. We can sometimes see, particularly when seizures start, a cognitive decline, which seems to associate with this kind of burden of disease and seizure activity. And in the most severe forms of disease, and even if we talk about infants with type 2 Gaucher disease, and particularly early on in life, if you've got a very severe type 3 Gaucher disease, we will see bulbar dysfunction as well. And so that can manifest with swallowing difficulties, choking episodes, and associated with that, you can have challenges with feeding. So the spectrum is really broad in terms of the neurology. Some of your patients will have all of these features. Some of them will have hardly any of these features. But that doesn't mean that they don't have type 3 or neuronopathic Gaucher disease. It is a spectrum disorder, and that's what we'll try and show you throughout this teaching session. So we've talked about Gaucher disease and neuronopathic disease having this neurological component, but the systemic manifestations are there as well. And often they're really quite invasive in patients with a type 3 Gaucher disease in particular. So you'll often see these are the Gaucher patients who present earliest in life. So typically I expect most type 3 Gaucher patients to present in early childhood around 12 to 18 months of age. They have hepatosplenomegaly, so enlarged liver, enlarged spleens, and they are vulnerable to all of the complications that a type 1 Gaucher patient would have as well. So that is bone disease, that is hematological abnormalities, and also they get an addition of kind of more invasive, higher burden of disease. So we often see, particularly in little children, lung disease, which is in part because of the compressive nature of having an enlarged abdominal organs, and also spinal deformity, but it also can be pulmonary infiltration. And I think we'll talk about that a little bit more in the next session when we talk about complications of Gaucher disease. So when you're looking at your patient, the things that we really want you to be thinking about are unexplained splenomegaly. So most patients at presentation will have splenomegaly. And so this can be really massive and it can be really debilitating. And so that's your first thing that you need to be thinking. Do I need to think about Gaucher disease in this patient? Many of our patients, majority of them, will have thrombocytopenia at presentation, and it can lead to this disproportionate bleeding tendency in relation to that platelet count. And then remembering this gaze palsy sign. So we describe it in lots of different ways. You'll hear about saccade initiation failure. You'll hear about horizontal gaze palsy, supranuclear gaze palsy. We're all talking about the same thing, this difficulty in moving the eyes between 2 points. And what I would encourage you to do is just practice examining on healthy patients, so that time when you do it on a patient who is affected and you think, oh, is there something different there? You're probably right, because you're so used to seeing that normal quick movement between 2 target points. So head still, looking at the eyes between 2 points, or a real tendency to want to move the head when they're doing that movement. And you'll probably be right. You'll probably pick it up, but you have to do it regularly to see it. Other clues or worrying signs or things that will mean that you need to look further, you need to start investigating more, is if there's a high ferritin, if you've got somebody presenting with chronic bone pain. So this might be an adult patient, it might not be a pediatric patient. It could be bone pain and fatiguing easily. If on imaging, so you've done an X-ray and you've seen this Erlenmeyer-Flask deformity of long bones, and particularly in children, of course, one of the key things that we think about all the time in any pediatric patient, if a child isn't growing, we have to find a reason for why they're not growing. And we shouldn't be dismissive of that. And so look for the organomegaly, look at their blood counts, and wonder if in this patient, could this be an explanation? And so then again, just thinking a little bit differently when we're thinking about GD3, thinking about children versus adults, because they will present differently. In pediatric patients, which is the group that I typically work with, most of our patients are diagnosed because they come into hospital with recurrent chest infections. So they're in more than most other children and they get recurrent breathing difficulties. And at some point on that journey, somebody either does a blood count and realizes that they've got an unexplained thrombocytopenia, or they palpate the abdomen properly and they discover hepatosplenomegaly. And that's the typical presentation. Around between 12 months and 18 months of age is the typical presentation for a type 3 patient in the UK. And I appreciate there may be vast differences in your experience. And so it'd be really interesting to hear those and to see how things evolve. But that would be the key presentation for a child. They typically will go on to have identified developmental difficulties. So that might be gross motor delay, that might be learning delay. Often I've seen speech delay in our patients as well, and some of these social communication differences, so autistic spectrum type presentations, sometimes ADHD as well. We see the gaze difficulty that we've talked about. If we go looking for it, we might miss it if we don't look for it. But what you probably wouldn't miss is a squint, so a strabismus. So in turning of the eye, you typically wouldn't miss that. And while that can be common and part of healthy childhood, if you put that in the context of a child with organomegaly, with low platelet counts, I would be thinking about GD3 as a diagnosis. And a really interesting and important point, particularly into, once a child is ambulatory, they typically will have a very specific posture with GD3. So the children will have their head flexed back. We think that this is mostly to do with their eye movement. So they'll often come into clinic, but you'll see they're curved back. They may have anterior chest wall deformity evolving as well. And I see that mostly around the age of 3 or 4. But the kyphosis and often scoliosis, you can start to see it evolve at any time, but it becomes more apparent during periods of significant growth. So kind of 12 to 15 years of age, you might see that really become apparent. And the earlier age group, what you might just see is a hyperlordosis. So they just have that extra curvature at the bottom of their spine. But if you see a kyphosis or a scoliosis, particularly in the context of Gaucher disease, and it's somebody under the age of 16 and there's no vertebral disease, so the bones look healthy, but it's curved, to me, they have neuronopathic Gaucher disease until proven otherwise, even if you are struggling to say confidently whether the eye movements are abnormal or not. It's almost as clear as the eye movements to me, if there's no vertebral disease there. So that's our kind of childhood picture, a kind of rapid overview of those patients. And when we think about our adult patients, so their Gaucher disease can present in lots of ways. So we've seen patients come with, early joint replacements described as having, arthritis or something, and somebody's really thought about it and they've had a pre-op check and their platelet count is low, and then somebody thought, well, I should maybe just check their abdomen, and that's how they've reached diagnosis. But in terms of their neurology, again, it can be quite subtle if they're an adult presentation. Eye signs again, but often the ataxia, tripping up, and then maybe seizures are a kind of later presentation if in a patient that hasn't had a diagnosis in childhood. So the symptoms may have been subtly evolving, but they've been explained away over time because they've got a diagnosis or they were anemic and, they're a little bit behind in school, and, the things can be a little bit more vague, and you have to have a higher index of suspicion, particularly for our adult GD3 patients. But really, when you're seeing a new Gaucher diagnosis or you're thinking about a Gaucher diagnosis, the earlier the presentation and the more florid that systemic disease is, the more likely this is to be a neuronopathic presentation than it is to be a GD1 presentation. So what are the real essentials that you're seeing a patient in clinic? What are the absolute musts that you should do? And this was interesting because we talked about this, and I was seeing a Gaucher patient in clinic yesterday, and I was thinking, what are my key questions that I ask every patient? And some of these are things that I've inherited. There was a very eminent professor that worked in our hospital many years ago, and he had a little checklist that he asked every Gaucher patient that came in. So key things that we always do in terms of examination is abdominal examination. So get your hands on the tummy and assess spleen size, liver size. Look at the eyes, and do it in everybody, regardless of diagnosis, because it'll help you get really good at making that assessment. Do a bleeding assessment. So look for signs of bleeding, look for petechiae, look to see if there's evidence of bleeding when they're brushing their teeth, or is there bruising? Do they look like somebody who's easy bruising? and do a bone examination as well. So this is looking for tenderness in long bones, looking at joint deformities, and again remembering to look at the spine, and just don't be shy to do that on a regular basis as you get to know these patients. And again, I guess you should probably add into that the anterior chest as well, for deformity there. And then we start to think about tests. So the key blood test that we say that you should be doing is a full blood count, a ferritin, and looking at liver enzymes as well. And we can talk a little bit about the rationale behind that. And if you've got them available to you, these are the kind of 3 key biomarkers that we're currently using, and that if you can access them, are really helpful to you, and they give you an idea of active disease, which is really helpful, especially if you move into an area where you can offer treatment. So the Kaito level, the glucosylsphingosine, so these are all, so the Kaito from your macrophages that are activated, your glucosylsphingosine is a kind of substrate marker, and PARC and CCL18, which again, these are not widely available at all centres, so it's certainly something to think about if you have access to them or you're given the opportunity to use these tests.
Right. Thank you, Aimee. So I'm going to take over now for a few slides and think about the diagnostic sequence. So how do we make that diagnosis of neuronopathic Gaucher disease? And this is, of course, driven by your clinical suspicion. And I hope what you've understood from the previous talk from Aimee is that a lot of the clinical suspicion will drive the question of, is this Gaucher disease, and also if it's neuronopathic. The diagnostic sequence is not too different for types of Gaucher disease, and ultimately the classification depends on the clinical phenotype, can be helped by the genetics as well. So the first step will be to achieve enzyme testing. And in a usual situation, the requirement would either be to have peripheral blood or cultured leukocytes, but you can use dried blood spots for initial testing, and that can be helpful, particularly if we're having to send samples over a long range. And the diagnostic threshold will be determined by individual labs having their own cutoff ranges, but below 15% of normal glucocerebrosidase activity. And then we would always want to have genetic confirmation. So in Gaucher, diagnosis is on the enzyme activity, but the genetic confirmation will allow us to understand more about the prognosis of the patient, to confirm the diagnosis. And the primary method is therefore the sequencing of the GBA1 gene. We might need to do MLPA analysis for large deletions, which do occur in some cases. And then ideally, we would also, in a new family, look at parents to make sure that we had segregation of the alleles with the parental samples. And then as an additional confirmation, we would want to look at some of those biomarkers, both because they are helpful in being really clear on diagnosis, but also in longer term monitoring of patients. And these are the things that Aimee just mentioned, so glucosylsphingosine, chitotriosidase, and PARC. But of course we've got them up, it's great, may or may not be available. So the IWGDD has put together some guidelines for what the quality standards and laboratory requirements for diagnosis would be, and those are available on the IWGDD website. We do suggest accreditation of the labs according to ISO 15189. Again, we have to go with what we've got available, but that would be our ideal. And that means that with those labs would be using quality controls. So they would be looking for appropriate positive and negative controls in any of the diagnostic assays, particularly if we were looking at family screening or trying to look at mutations which had already been seen before. I've put on there some of the sample handling requirements if we're looking at either dried blood spots or blood samples, and then what we need for shipping, because it may be that you have to ship quite a long way. The main advantage of dry blood spots is that they are easier to handle. You can keep them for quite a long time. They are more cost effective to ship. You can post them a long way, and some of the infection control requirements are obviously less for shipping dry blood spots because it's easier to contain them. And then once having achieved that diagnosis through a combination of the enzyme activity and then, if possible, an available mutation analysis, we want to look at protocols then for further evaluation of the patients. And these again will depend on availability. So even within the work that we've done in creating guidelines throughout the UK, there is some variability, and it may not be that we do all of them in every patient. But some people would consider a brain MRI and look at sequences to look for subcortical atrophy. Sometimes see white matter lesions. We see abnormalities in the basal ganglia, and we might, in those patients, use serial imaging for disease progression. But in many patients, the brain MRI is actually not informative. So I think we have to use some clinical assessment there as to whether we would want that. We definitely want to have a bone assessment. And this could take the form of a long bone MRI to look for Gaucher cell infiltration, differences in T1 and T2 signaling. That helps us to understand both the burden of disease, and there are scoring systems to assess that, but also to look for differences in fracture risk, and potentially in areas where there may already have been fractures which might need to be addressed. And then we could also use a DEXA scan to look at for osteopenia, and X-rays to look for abnormalities. These are both also very useful in potentially suggesting diagnoses. So although we use them for longer term evaluation, it may be that your patients have had MRI which has had some suggestive features, which means that this is the route into their diagnosis to you. And some of our patients with Gaucher disease come through the route of rheumatology and orthopedic surgeons, for example. So in this case, I've got on the right hand side here some way of thinking about what a cost-effective testing strategy might be to try to alleviate some of the burden of testing via going for the most expensive test first. So you might think about DBS testing as a quick and efficient way of sending samples along with one of the biomarkers, because they can also be tested with blood spots. And then only if those are suggestive, go into a second tier of enzyme confirmation, and then finally genetic analysis. So this might be a workflow system for you. This is one of the models that's been adopted in Egypt by one of our colleagues who I'm just looking, I'm not sure is on the call, but who you may know. So there's consideration for an initial screening, patients with those clinical features that Aimee mentioned, so particularly splenomegaly, thrombocytopenia, liver abnormalities, eye and bone abnormalities, and then thinking about really what a short-term management protocol might be whilst we're waiting for that enzyme and genetic confirmation. So thinking about how do we address the really most significant clinical risk, so bleeding, for example. So how do we monitor platelet counts and then mitigate low platelets, avoiding aspirin and non-steroidals, for example. Thinking about infection prevention, some patients may, due to splenomegaly, have had a splenectomy. We would generally suggest that is not done as a therapeutic mechanism, but sometimes we come across patients where it has been done diagnostically. So we need to think about infection prevention generally in patients with GD3, but also post-splenectomy, pain management and nutritional support with all of the usual ways. And then surveillance, depending on our consideration of risk in our patients, between 1, 3, 6 months initially, And then we're going to talk about specific therapies later on, and then we can think about our longer term evaluation. So I won't go over these, but the slides will be available to you, so you can see some of the things that might be possible in terms of sample shipment. That information will be there for you. So one of the questions that we thought would be useful to have some consideration of is the difference between a variant of unknown significance and a pathogenic mutation, because this does come up from time to time and can be quite difficult to navigate. If our starting point is a patient with really typical clinical features that are suggestive of neuronopathic Gaucher disease, so eye movements, bone disease, organomegaly, and we find a mutation which has not previously been described but is consistent with Gaucher, with the clinical features and with low enzyme activity, then I think there is less of a discussion. But sometimes we have equivocal clinical features, a mutation which has not been described. It may be in the carrier state, so we're difficult to then interpret either the clinical features or the enzyme activity. And so we really want then to think about the pathogenicity of that mutation, particularly in family screening. So for somebody who has 2 alleles, so somebody with clinical features, then we would suggest that having a low enzyme activity going along with that is mandatory, really, for the diagnosis and to be able to classify a variant of unknown significance. And confirmation of that enzymatic activity should be in patient cells. So plasma is not helpful in the analysis in Gaucher disease. And you'll find that in our laboratory guidelines on our website from the IWGDD. The ASMG also has a system for understanding variants of unknown significance, and it might be worth working through those. But you also have the resource of all of us from the IGA and from the IWGDD. So if you do come across a mutation which is the laboratory has found difficult to classify, then coming and talking to somebody and we can look and see whether we also have had that experience. And that's something that I do on a fairly regular basis. If I make a diagnosis in a patient, I think they might be neuronopathic, clinically mutation maybe I've not seen before or not seen in that context, I email Aimee and say, have you seen this? And she's always very helpful and gets back to me with her thoughts on that mutation. There may well be higher VUS rates in your African population. VUS is just something which is uncertain, and that's because we have limited reference data. So we may have more uncertainty about mutations which are coming out of your diagnostic testing. And it would be really great to start to document that and to build up a database so we have more information. There are a couple of alleles though which have been seen in more patients from Africa. You can also take the mutations and run them through various databases. If they're available to you, they're usually freely available. You can search them, ClinVar, HGMD, ClinGen databases. They will tell you whether these genetic variants have been seen before, give you references to papers on them. Looking within families is really helpful. As I said, you want to find that both parents have the mutation. And then if all else fails and we're still not sure, then we would sometimes do functional studies. So we would take that mutation and look for expression in an expression system. And then we can periodically reassess that because the VUSs are inevitably reclassified. And I was looking in one of our other disorders over the weekend, and some VUS which we had been uncertain about a year or two ago. There are now more people with those variants documented, and I think the pathogenicity has been established. So things do change over time. So some takeaways. that we wanted to bring to you. So really is consideration of GD3. We won't make the diagnosis unless we think about it. So having a high threshold of suspicion with people with unexplained splenomegaly, particularly with any neurological involvement, eye movements or other neurology. So always testing the eye movements. We would do some basic laboratory screening, check the full blood count, check the ferritin levels, liver function can be really helpful. And then we try to, while we're keeping them safe, getting the diagnostic testing, looking at making sure that we can manage platelets and bleeding risk and so on, but really trying to avoid that splenectomy if possible, because the longer term morbidity that it brings with it in Gaucher disease, including worse bone disease. And then a diagnostic strategy, maybe enzyme with blood spots, working with our international partners, but using accredited laboratories wherever possible. And I've spoken a little bit about VUS. We do want to build up the long-term evidence, and that means keeping data, keeping databases where it's possible, building registries, and probably collaborating on registries together. There's a number of Gaucher registries, but in particular highlighting the IgA registry for neuronopathic Gaucher disease that the IgA might want to discuss. So I'm going to stop sharing, and we'll, I guess, keep on with the agenda. But I'm very happy to answer questions whenever that is appropriate in the agenda.
Thank you very much, Derralynn, Aimee, and we will answer all the questions towards the end. But before we give any context or any further information, I think it'll be really important now that I introduce one of my wonderful African doctors, which we worked together with for many years. I forget how many years already, and I'm always conscious of getting his name right. It's Dr. Augustin Tandenya from Rwanda. And I thought it'd be really good that he shares a case with us first, and then we can open up to questions and touch on many other topics. And I see some questions are coming already into the current chat box, and we'll do them all. So I'm going to hand over to you, Augustin.
Thank you very much. Thank you for the opportunity to share this case with you this afternoon. I'm called Augustin Tandenya, pediatrician. I'm working in public hospital, Kigali, Rwanda. Okay. The patient, 6 years, a male. The initial diagnostic was in 2021 for Gaucher disease type 1. He's starting treatment the same year. After 1 year, he developed a neurological sign as impairment swallow, abnormal ear movement. But I don't catch if it's horizontal, vertical, and recurrent bronchospasm. But now it's in a control with fluticasone inhaler. So after this neurological sign, I was discussing with Professor Chris about this sign. So we only of type 3, but sometimes I say it's type 2, type 3, but it's not easy to separate the two types. July this year, he developed tonico-clonic seizures, and we managed by electrodiazepam, and we do EEG, confirm epileptic activity. Was starting with CAPM, partial control. We add sodium valproate, also not full controlled. Until now, we have seizures tonico-clonic. So we send the patient to the neurologist to help us to manage the patient. Now it's under neurologist management. It continues with the same treatment, but just small adjustment of doses of Keppra. But still, the seizures is still ongoing. So on the physical exam, we saw the patient as failure to thrive, and we found also mass, palpated mass on periumbilical tenderness during hospitalization. We do an abdominal CT scan. There we found a large peritoneal nodular masses centering within the mesenteric, suggesting the lymphoma. This is the protocol for the radiologist. But after discussing with the pediatric surgeon, he said that it's possible the mesenteric lymphadenopathy. Mesenteric lymphadenopathy is described also in Gaucher disease. So we maintain this diagnostic and is still under monitoring with pediatric surgeons. So after this different presentation of this Gaucher disease type 3, we starting multidisciplinary management. So neurologist, surgeon, and the pediatrician. Soon we are associated also the nutritionist to help us to give a good care of this little daughter. So on summary, the primary condition was Gaucher disease type 3. The current treatment is on serenzyme given by Sanofi and fluticasone, Keppra, and valproate. The complication is neurological and surgical. And the next step now, with the step we have, is the multidisciplinary care. So this is the patient, is a short presentation. The patient still is not stable, according, still have the seizures, despite the valproate and Keppra. I don't know, it can help me to, if we can add another anti-epileptic to help if we can stop the seizure. Thank you very much.
Thank you very much for that presentation. And I think before we go to questions, and I'll direct them to now, but I think some context which is really important, which may not be obvious to those joining from the developed world, is firstly, we don't have genetics for many of our patients available. So which is why you start off with a clinical diagnosis on many occasions, and only as it progresses do we actually manage to find. There's a real problem sending any blood samples out because of the logistics and many of the other issues. So primarily we are dependent on DBS samples. And the other thing that will shock you is that actually we don't have any funding to test family members or the parents. That's not available. So we can only get diagnostics on a patient who's got an abnormal enzyme result. So, but this is what we deal with, and we're working on it, and we'll talk about the solutions and what we're building on at the moment later. But I just wanted to put that context, because if people are away from here thinking, what is happening here? And then the other really important point that Augustin made is, why did he say we couldn't make sure if it's Gaucher type 2 or 3? It's really important that in Africa, we tend to see a lot more patients with neurological disease, number one. But number two, they are incredibly sick. And a majority of them are sick when they're 9, 10 months of age. So you can see why people would think these are type 2. But they are, now that we've genetics, we actually know they are classical type 3 Gaucher, but they just a sort of incredibly significant severe disease. And this is what we're battling. And as Aimee and Derralynn was talking, I was thinking, I cannot recall a single adult type 3 Gaucher patient in sub-Saharan Africa. So either they never make it there, or we're not diagnosing them, and that's a different discussion. But I thought that would just be a context before we go further. And I'm going to take Augustin's question first, because it's a clinical one to you, Aimee. any advice you can give about managing the seizures?
Yeah, and there's also a question I can see in the chat that's also talking about seizure control in the context of GD3 as well. And so the short answer is there is no specific protocol that is GD3 specific for seizure management. So there isn't, you know, like the perfect drug that we say, actually, this works really well in all of our patients. So we certainly treat seizures the way you would for an epilepsy diagnosis, in the sense of look at the type of seizure, the seizure's emiology and the frequency, and think about what drugs you have available to you, because that's the other thing that I guess we need to consider. So we have a whole range of kind of new generation anti-seizure medicines, but I don't know which of those you would have access to. I think the combination that you've started with is really sensible, and they would probably be our first choice for a generalized epilepsy. I guess my only other little thought, so two things: whether you have access to kind of things like clobazam and rescue medications, that, you know, general benzodiazepines, which are quite useful, and other drugs like phenobarbital, old-fashioned anti-seizure medicines, which actually can be really effective, or that you just have to balance the making them too sedated. But we could certainly look at the specific case kind of offline and think about what else you've got access to that we could support with. And the question in the chat was just asking about the role of enzyme replacement therapy in terms of managing seizures. And what I would say about that is, so we know that the enzyme replacement therapy, even if a tiny bit of it crosses the blood-brain barrier and gets into the brain, it doesn't stay there. So it doesn't affect the neurological symptoms of disease. However, I have a strong belief that if you have good systemic disease control and good overall general health, that will help your brain health. So debulk what you can debulk, and you will limit that disease progression. And by maintaining nutrition as best you can, you will also help your brain health. So although it's not a direct benefit, we all know that seizures are worse when you're tired, when you've got infections. And so if you're not growing and you're not nourished well, then your seizure burden is likely to be worse, and your threshold for seizure activity is likely to be lower. So I think, you know, just being really holistic in that approach, because you've got limited resources, so you have to do what you can do, and so use what's available to you. But yeah, although ERT isn't CNS penetrant, I think it has a role still for those in terms of the neurology in the context of Gaucher.
Good, thank you. I think the next question I'll quickly grab and then I'll get back is more, how can we test parents with Gaucher disease? I've already touched on it, we don't have funding, but on the positive side, we are setting up Gaucher testing with the excellent team of both the South African Medical Research Team and the laboratory in Northwest South Africa. So we are hoping that over time we will actually have the facility that we will be able to do extended family members, and we're always begging for money, but that's a different option. So we won't talk too much about that. So the next question I think I've touched on, which is from Aidan, can you suggest the epidemiology across Africa? I think, like I said, in general, we seem to have a lot of type 3 disease, quite severe, very early onset. There is a significant type 1 founder mutation as well, and that interestingly has also quite significant disease, but does wonderfully well on enzyme replacement therapy. So that's just the quick one. There is enzyme treatment. Okay, question I'm going to throw out to the two of you. How can we treat the mesenteric lymph nodes, and is it addressed by ERT?
Yeah, so this is really common to see lymphadenopathy, particularly in our GD3 population, and particularly in certain cohorts of patients and certain genotypes. So there can be incidental findings of mesenteric lymphadenopathy, which causes a little bit of abdominal pain, but seems to just, you know, kind of, it's there and it's present, but it doesn't cause a protein losing enteropathy, and doesn't become so significant that it's it's that problematic. And sometimes we just see those lymph nodes kind of just regress over time. They become calcified and they don't cause any further problems. In some scenarios, which sounds like this particular case that's been presented, they can form these kind of larger masses. We used to call them Gaucheromas. I'm not a big fan of that name, but it's the same kind of terminology that we're talking about, a kind of mass of lymphoid tissue with Gaucher cell infiltration. And they can become really problematic. And so they can cause a protein losing enteropathy. And I think we'll touch on this as one of the complications in the next session as well. So ERT doesn't seem to prevent that from happening and doesn't seem to treat it. But there are some reports, and we've used substrate reduction therapy as an alternative. So eliglistat is the kind of approved substrate reduction therapy, hasn't really been used as frequently in children, who are the ones that seem to have this problem more predominantly, so can be used. But I think we've also seen a really good response to using steroid medications where there's been a protein losing enteropathy. So it's when that infiltration has gone on to that next level of complication and children are losing, so they've got really profuse diarrhea and they're not absorbing their nutrients, and they've got this low albumin levels. So budesonide typically is a kind of steroid of choice if that's accessible, but with nutritional support as well. So the nutrition needs to be there, and really specialist support from a dietitian, really. But again, it's that kind of using what you've got available to you. I certainly would use the enzyme replacement therapy, but I don't think it's going to stop. When it's going to happen, it's going to happen, and the ERT is not going to stop it. I don't think we've ever been in a scenario where a child has had a lymphadenopathy before they've started ERT. So that's not something I've seen. So I think most of the time we've seen it in the setting of already being established on ERT and having had a response to ERT to that point.
You want to add anything, Derralynn?
No, I agree. I think it also speaks to one of the other questions around, what the modalities of treatment. Yeah. And essentially, what we have approval for is enzyme treatment. And since none of the treatments have been shown that are currently approved have been shown to cross into the brain, I think we need to use treatments which actually address those systemic manifestations in order to give good health, and as Aimee says, potentially also help with the wider neurological complications, not because they get into the brain, but because they keep people in better overall condition. So the only experience we really have with substrate reduction therapy in neuronopathic Gaucher is in clinical trials. And so that may be something in the future which becomes available, but not currently, or a few patients who are receiving additional therapy because of significant complications. But there's not really any evidence for that yet.
Yeah, and thank you, Derralynn. And I'll put it out there as a teaser. In the series, we will talk about new therapies and things later on. So you're going to have to wait for next year before we talk about that, because we're hoping there may actually be some public data which we could talk about potentially, but I can't promise anything. So you have to do that in the next year. And Aimee, I know you need to drop off at some point, but I am going to put you on the spot. If you want to try and show those videos for us quickly, I think it would be really useful. Yeah. And then if you need to drop off, that's fine. And I'll see if there's any other questions, and then we can get the polls as well going. But I don't want to miss the opportunity. I think they're really useful. Just if people have never seen them, they're really useful to see.
Okay, so this is a really old video of my eye movement. So hopefully this will play for you. And so this is just to show you that's what a saccadic eye movement should look like. Nice and quick, moving from side to side, quite a jaggy movement. So that's normal. And so you can practice looking at your colleagues, your friends, your family, just get them to look between 2 points and tell them to keep their head still. Let me just put the volume down. So this is me with a colleague many years ago in our A&E department, and this is what I always start with. So this is how I examine them. So I ask them to follow a moving finger. So by doing that, so this is smooth pursuit movement first, and that just tells you that they're following your instruction. So that's all that that's there for, and that you can see the eyes move. Then you give them 2 targets, ask them to keep the head still and look between them, and I do horizontal and then I do vertical. In small children, that can be tricky, but I sometimes use, I've got some little finger puppets, so I put finger puppets on. You could draw little faces on your fingers, just make it into a game if you're doing this with children. So smooth pursuit first, and then holding 2 targets and asking the person to keep the head still and look between the 2 targets.
Good. Thank you, Aimee. And if you need to dash off, Aimee, we will know and we won't blame you on that.
Thank you so much, guys.
So, and I think Aimee's going to jump off. And is there automated system for evaluating saccades? I think Aimee is the right one to answer that question. I know there are some. However, their reliability, I think, was questionable before, but then things are always improving. So I don't know if anybody else. Derralynn, are you aware of any of those?
I'm not. And I would hope if there was, it would be somebody who developed something and made it widely available. You could imagine that an app through an iPhone might be a good way of doing it. So perhaps something we should think about.
There is already an app, but I am slightly dubious about the reliability of it. But yes, there's an application in the App Store already, and it's a start. And I think that's always, I think we always need to say, don't say everything is bad. I think it's a start. And we may talk about those later as well. There's also some fantastic work going on, and I won't spoil it, but on vocal biomarkers potentially in Gaucher disease. So there's lots of new things happening, but that's for another topic, and you're just going to have to wait for that. I don't see any other questions at the moment. So while everybody's still around, I am going to see if I can launch the quiz for you to get your if you could please start answering let me see, can everybody see that poll? And you can get your QR code as things as well. So if you can please help us to fill this in. This is really important. Again, as I thank the patients, it's also to try and help us to develop services and things like today, highlight some of the issues, the very difficult, Derralynn talked beautifully about the International Working Group guidelines, but many of those things are not accessible to us at all. But they are attainable goals for the future. And that's why I really enjoy seeing them. Because we work towards how can we get there and how can we manage to get to those levels. And there's a lot of things happening in Africa at the moment, so a lot to be excited about. So I'm really wanting you to do it. And you will need your QR code, from what I understand as well, to get your CPD points. So those who's keen on the CPD points, it's just a gentle encouragement to get you to fill this in while it's ongoing. And then for the people specifically online from Africa, I just thought it will be a really good time just to mention at the moment while people are filling in the poll. We do have a project together with the IGA and Northwest University called the Africa Roadmap, where we're actually rolling out diagnostics across multiple countries in Africa. And one of the main goals for this year and running into next year is actually to improve the genetic diagnostics in-house. And we've been very grateful that we've had some funding to start setting that up. And that's work which is started already. And there will be more and more coming through as time goes on. So lots of things happening. So don't get disillusioned, but there are things happening. And just for context again, like I've said before, it's near impossible to get samples sent out. And to give you an idea, when we did the roadmap project, the samples took an average of 12 days to get into the laboratory, but up to 122 days. And that is because of both logistics and customs. And the team works very hard around how to solve that and finding solutions for all of that. So I think it's really important that people are aware of it. And please follow us and keep an eye out for the Africa Roadmap project, where we will be sharing more and more information about how to collect the samples, who to contact, what is the process, and you've got another 3 webinars to follow. So I'm not going to spoil everything. You're just going to have to come out, and I'll get Tanya to confirm for me off the top of my head. I think the next one is the 17th of October. Have I got the date right?
You certainly have, yeah, and we'll be sending everybody who registered for this webinar today, we'll be sending you a link to the next in the series, which is in October, and then we'll have a 2-week break, 2-month break, and then we'll start again in the new year.
Thank you for joining today, and please remember it will be available once we've edited and make sure it's correct, and it will be available then, and we'll share the link, because I know a lot of people are in busy clinics and couldn't join at this time, but it will be available and you can rewatch it again. But thank you so much for your time, and thank you for the expertise and knowledge shared, and thank you for just being part of this effort to help patients improve. Thank you. Have a great evening.
Yeah, thank you so much, everybody. And we'll have our session before the next one. Enjoy the rest of your day. Thanks, Chris. Thanks, Derralynn. Thanks, Austin.